Welcome to the Clinicians Coffee Chat on Encampments. I'm Lily Catalano, Project Manager for the National Healthcare for the Homeless Council, and this is the first of this Coffee Chat series, which is intended to be an informal setting for us all to share questions, ideas, challenges, and support for one another on a given topic. So get your coffee or tea or beverage of choice and we'll get started. This series was developed by the Healthcare for the Homeless Clinicians Network, which is the nation's largest network of providers of hands-on care to people who are homeless. The network helps members connect, learn from each other, and share best practices across the homeless healthcare field. If you're not already a member of the Clinicians Network, please join for free via the link in the attendee chat box on your screen. And before I introduce our presenters today, I'd like to learn a little bit about who's participating in this chat. We've got a great group of folks in the room already. There's a poll question on your screen that you can click in response to right there. And it asks, what is your primary role with respect to encampments? Are you A, direct service provider currently providing care in encampments? B, a direct service provider not yet providing care in encampments? C, an administrative or management role that is not personally providing care in encampments, but perhaps you oversee staff that do, or you're determining your agency's role? Or D, a public official or other role? And it looks like we've got a real mix of folks in the room. The biggest group is administrative or management folks, but followed closely behind by direct service providers already providing care, and then folks not yet providing care in encampments. Thank you. A couple of instructions about how you can engage during the chat today. We want to hear from you, and we're using an integrated phone line through the webinar room. So all participants are muted now, but if you would like to speak up verbally with a question or comment when we get to the Q&A parts of the session, you can do that as long as your computer has a microphone. And the way to do that is to look on the gray bar on the top of your webinar room, and there's an icon of a person with their hand raised. If you click on the menu next to that icon and select Raise Hand, we will call on you and unmute your phone line for you to speak up and ask your question or share your comment. If you don't have a microphone on your computer or you don't want to speak out loud, you are still able to type questions or share any comments in the attendee chat pod. And that's on the lower left part of your screen below the PowerPoint slide. So I'm thrilled to introduce you to our facilitators today. We're joined by Dr. Barbara DiPietro, who is the Senior Director of Policy here at the National Healthcare for the Homeless Council, and Brian Bickford, who is the Central Massachusetts PATH Team Leader at Eliot Community Human Services in Worcester, Massachusetts. Brian also serves on the Clinicians Network Steering Committee. So welcome, Barbara and Brian.
Thank you.
Take it away, Barbara.
All right, very good. Thank you all for coming out today. Trying something new with this format, and so as Brian and I are talking and raising issues, please feel free to type your questions in. We really want to get a robust conversation about what struggles you're having providing services in encampments, where you see opportunities or best practices. We're trying to learn from each other as a community, as Lily had said. So I'm excited about this and merging policy with our service delivery, which I think is a really important piece. For today's discussion, we wanted just to talk about the context of encampments, and the environment that we're working in right now can just seem really difficult. There's a number of things coming together all at once that create sometimes a very complicated environment for service providers in particular. We want to talk about the principles of care that guide service delivery for this population, some of the benefits and the drawbacks to that care, strategies that have proven successful for creating safe spaces, And then again, a space for us to talk about what you're seeing and the issues that you'd like to raise. I just want to begin by kind of an overall picture about what unsheltered homelessness looks like in the United States. This is just point-in-time data at the national level. So we know that there's limitations to this. You can see that we've got a lot of people, about 192,000 people who are experiencing unsheltered homelessness, and these are the folks that were counted. And we know the limitations to point in time. It misses a lot of vulnerable people, particularly folks who might be in smaller encampments that are back in rural areas in particular, or areas that tend not to be part of a consolidated downtown area that might get included in account. So this is a very conservative estimate, but still gives us a picture. And then some of the data that HUD reports nationally looks at some of the clinical conditions that, again, are reported through the continuums of care up to achieve this national roll-up. And we can see that people with behavioral health disorders are a good section of this, but not all. And we're seeing special populations like people with domestic violence histories, veterans, unaccompanied youth is obviously a very specific population that we want to tailor our services to. And so we know that there's a lot of issues that are happening here. Your community might look very different in terms of its clinical composition of people living in encampments. So again, this is just a national picture, but one that just provides some context to clinical issues. Want to talk a little bit about the rise of encampments. If you have not seen this new report from the National Law Center on Homelessness and Poverty, please check it out. It's a really great report looking at the rise of encampments over the last 10 years. And they've been looking, they used media reports and how often media was reporting on the existence of encampments, how large these encampments were. And they did a really nice breakdown about how we're seeing more and more encampments rise up in all communities in this country. And this is both urban settings, rural settings, and everything in between. They're finding a lot of small encampments, but then also large encampments. And so this is a little bit of the demographics they've found. Part of this, as we all know, there is a dearth of affordable housing. We don't have enough supportive housing. We don't have enough housing units in general to be able to match people to. That said, we also don't have enough shelter beds in most communities to meet the need. And we know that of those communities that do have shelters, those shelters don't always serve people who are very vulnerable very well. We know shelters tend to bar people who have got behavioral disorders or behavioral patterns that create safety issues. And so there are some legitimate points to those rules. At the same time, many communities don't have truly low barrier places for people who've got more vulnerabilities to stay. And then that creates the need for where do people go if they can't access housing and they can't access shelter. And this is why we've got more and more encampments. And in fact, this study showed that there's been a 1,300% increase in media reports since 2007. At the same time, about half of those relatively small encampments, maybe 11 to 50 people, but almost 1 in 5 encampments had 100 or more people. And we know those are the ones that tend to get the most media attention. But again, in your local community, an encampment with 5 people can be the one that really ends up creating tensions with community partners, political leaders, other service providers. So again, it's that teasing through the environment that we're working in and delivering care. There's a lot of conversation going on right now about sanctioned encampments and whether encampments should be allowed, or what does that look like? Self-governing encampments. How does consumer-led governance facilitate some more orderly outdoor spaces? Again, I think a lot of localities are struggling with some of these issues, but nonetheless, it puts us and the patients that we're serving in a really difficult position because there are often no alternatives for people to go. So I think this is one of the, certainly the trends in the country, but it's a trend that's really pertinent to us as service providers and how we're able to deliver care. And then finally, I just want to talk a little bit about some of the common responses that we're seeing to encampments. We're seeing more and more communities criminalize the existence of people who are homeless, so living their daily life in public spaces. So we're seeing an increase in no sit, no lie, no camping, bans on food distribution. We're seeing a lot more arrests and citations. We all know that this is not a constructive response. We know this is certainly not a solution to homelessness. And we know, frustratingly, that when camps are swept, it just disperses the problem and it doesn't actually solve anything. We know that in many places, there's no notice required to sweep an encampment. So it's hard for us to really work with the clients that we're serving to be able to be a partner and a trusted voice and saying, okay, you know, how can we prepare for something? How can we hold on to medications or IDs? And often what we know is these are things that are lost. And so we're in a position of not only replacing, but then managing the health conditions that come from losing all your medications and losing these pieces. And then again, few have requirements for alternative housing. So you're seeing sweeps of encampments without people being placed in appropriate long-term permanent housing. We're seeing also that local policymakers, local elected officials, and just the communities in general are growing very weary of what encampments look like in their community. And we're seeing what is called compassion fatigue. Some of this is driven by, or is evidenced by, the increased criminalization. So as communities just get more and more taxed and say, we don't, want this in our community, we need to do something. And they're pressing elected officials to be active and give even the appearance of doing something. And sometimes the appearance of doing something is enough, but we know that that is not enough. We know that sweeps, we know that criminalization, we know that short-term Band-Aids are not a solution to homelessness and are not a solution to encampments. And so this puts us kind of in a place where HCH and other healthcare providers are fulfilling numerous roles. So our roles as healthcare providers is obvious, and that's what we'll be focusing on today. But we're also community partners. We are trusted partners with our mayor's office, our city and county council members, our community partners, other people who rely on us to be working in collaboration. And sometimes those relationships get strained when there's a difference of opinion about how encampments should be addressed, what should be done, what we should be doing. Sometimes we're in a position where just the very fact that we deliver services in an encampment means that we are somehow sanctioning or endorsing the existence of encampments. As we all know, and Brian will talk at length about, we're doing what we do. We meet our patients where they are. We deliver the care that they need. But I think that dynamic with our community partners can sometimes be fraught. And that can have a chilling effect on whether or how we deliver care. And then finally, a third role is our HCH is a champion for change in preventing and ending homelessness, in pursuing the kinds of macro level change that we know is truly needed in order to stem the encampments and really provide permanent long-term solutions to housing for the people that we're serving. So with that, just as a brief policy context to the world that we're working in, I'm going to turn it over to my colleague Brian, who can talk more about the clinical delivery of services, and then we'll open it up to discussion about where we all are on this issue and what our ideas are for really best practices in this field. So Brian, take it away.
All right. Thank you very much, Barbara, and thank you all for being here. Just wanted to give just a quick little background. I am a behavioral health clinician. I oversee a small team of PATH, street and shelter outreach workers, as well as peer specialists. I have also been the director of a Healthcare for the Homeless program here in Worcester, Massachusetts, as well as a behavioral health clinician within a clinic, within that clinic here. So I have seen some of this, some of the questions about encampments and safety and how we operate differently within a clinic and outside of a clinic from a few different perspectives. So today I'm going to do my best to talk about some of my experiences in providing care to individuals in encampment, and also how some of that service delivery can and is different. Some there's drawbacks, there's some positives, and so we'll talk through some of those, some of my experiences, and then, as Barbara has said, we'll spend probably the last half of our time here, hopefully delving into learning from you all. You all are the folks that are out there, whether it be administrators helping to change policy and to support your staff, or outreach workers, city officials, those sorts of folks who are also doing their part within this dynamic that we're working in. So I'm just going to hit kind of some of the highlights of the next few slides, and starting with encampments and how they're different than traditional care environments. Clearly, it's a much less formal environment, which I think is both positive, as well as might have some drawbacks for some individuals. And as we start talking about providing care in encampments, I'll highlight a little bit about that. Another really important thing to just keep in mind when we're providing service in encampments is recognizing and knowing that the structure of the program or of a clinic within four walls isn't necessarily going to be there. Not that your administrators or your program is not supporting you, but the actual structure and support. If something does go wrong, who can you call on? If it's you and your partner, there's two of you, as opposed to at your clinic, there could be 10, 50, 100, 400 plus, depending on the clinic that you're working in. So just be aware of that structure, and knowing where your support is and what you can do to ensure that you're receiving that support. Something that was really interesting to me as I transitioned from a more clinic-based setting to providing care within encampments was I had, as we all have, seen folks who struggle with substance dependence, who are actively intoxicated or actively drinking, using within our clinics. But typically there's some sorts of rules and some boundaries that I think as a result of being in a clinic, of course, people will push those boundaries, and yes, people would drink in the clinic, and we would see that. But being out in encampments, that was something that, or just in the community more, but specifically in encampments, something that I've seen a large increase is people's comfort and use. So really thinking about what are your organizational, your personal, your professional thoughts about open substance use in encampments, in the community, and what is your line? What is your line in the sand that is always ever moving as we're meeting the individuals we're working with wherever they're at. So recognizing that people might be more comfortable in their own space or in an encampment outside, but also recognizing some individuals might not feel as comfortable. And we'll talk about privacy and confidentiality and trauma, but just recognize that some folks might be more comfortable meeting with you outside in the community, other people might not. And then just the other last difference, and of course this is by no means an exhaustive list, these are just some of the things that I run into quite frequently, is just access to the things that we might need, whether it be doing intakes and having to do them on an electronic health record, and bringing a laptop or a netbook or something out. But also keep in mind that there's a good chance that you're not going to have all of the medical accoutrements that you need, things that you need to provide care, to someone within an encampment. So, what is it? What do you pack? What are the things that are absolute need items, and how do we work around being able to still provide the best level of care we can with individuals wherever it is that we're meeting them at? So just taking some of the differences a little bit further. So clearly there are a ton of benefits. I've listed a few that individuals that I have served have let me know are actually benefits or positives of me being able to meet with folks out in encampment and wherever it is that they are. Um, is oftentimes that might be the most comfortable place for them, despite knowing that sweeps are happening. But they have their friends around. They have their other folks that they're camping with, the folks they're living with that are there looking out for them. And being in a clinic setting where they're trying to avoid certain individuals is definitely something that happens for folks. So really recognizing and talking to people about where is it that you feel most comfortable receiving services and being able to meet people where they're at, but knowing that oftentimes people feel more comfortable out wherever it is they're staying. I think a big part of that is authority figures. I think, as we all know, a lot of the individuals that we're serving and that we're working with, maybe even some of us ourselves, might have some issues with authority figures. And having someone telling us where to stand and which line to be in and when to be able to go to the next window can be really frustrating and trauma-inducing for some folks. So that's something that people oftentimes say, well, I don't want to go to the clinic. There's a security guard there, or the person at the front desk doesn't treat me well. All of the experiences that people have with authority figures. So just recognizing that. I've also gotten a lot of kudos and folks that really appreciate all of us, all of our outreach workers for actually venturing into the community, for being in the community to talk with folks, to meet them where they're at, to see what some of the realities of the life that they're currently living are. And that I think a very important aspect of trying to form a relationship with someone and not just hearing about it, but being able to see it firsthand. Um, we'll talk more about respecting autonomy, but and this is a very big sticking point or issue for me that I've seen a lot of other outreach workers not really respect the space of a homeless individual, whether it be going through someone's tent when they're not there, trying to figure out who is staying there, or staying outside of a tent and asking someone to come out, which I'll talk a little bit more about in further slides. But really respecting individuals' autonomy and knowing that this is where they lay their head at night. This is their home. This is where they're currently sleeping or staying, and making sure that we are welcomed in to that space and that we leave whenever it is that they ask us to leave. That is not our space, whether it be a sanctioned site or an unsanctioned site. So just really respecting individuals and other human beings. Um, it can also be less stigmatizing or traumatizing for individuals, whether it be authority figures, whether it be going to a clinic and it being kind of a sterile environment or not as welcoming, not as comfortable for those individuals. So just some things, some benefits to delivering care in encampments, and we can talk more about these as we move forward. Some of the drawbacks, and some of these are really big and things that I know we're all dealing with every day. Privacy and confidentiality is, of course, paramount in the work that we do. And it's something that from the very beginning of the treatment relationship that I speak very openly with the folks that I'm working with around. I'm not, whether you give me permission or not, I'm not going to be talking to your campmate or someone else that you know in the community about what's going on, even if you tell me that you feel comfortable. I've had these situations come up, and many of times, and as long as we can be true to our statement and be very clear with the individuals we're serving, that we will not divulge any information, and that privacy is really important. And that goes beyond just with other people in their encampment, but also goes on to, you know, other outreach teams, other outreach workers, other mental health departments or city departments and that sort of thing. And I know that definitely has been a sticking point at times. And we want to collaborate and work as well as we can with everyone, but it has to be within the bounds of HIPAA and confidentiality and privacy. So I know that's a whole nother topic that we could do an entire coffee chat on at some point. As I spoke about earlier, active substance use, whether it be, as we've all seen, individuals that are actively using illegal substances, legal substances, and knowing when to engage with individuals or not, and having a relationship with folks to be able to say, maybe we should look to only have a morning appointment with you because by the afternoon it gets tough for us to do some of the work that we're doing. I can still come see you, of course, but let's try to do the best that we can so that I'm able to provide you with whatever it is that you need. The last slide, we did talk a little bit about support and safety. So really taking into consideration, knowing where it is you're going, making sure that your organization has policies and procedures. Do you go to an encampment by yourself? Are there times that you will, but times that you won't? I would say, in general, our rule of thumb is always go in pairs. But there have been times that we have, a relationship with someone and have made a decision and have informed someone, this is where I'm going to pick this individual up, this is where I'm going to be. So just taking that extra step of planning for safety to the best of our ability, knowing that we can't plan for everything, but we want to make sure that we have everything as put together as we can so that if anything does happen, we are ready and prepared to deal with it. So I think the beginning of working with individuals in encampments and the work that we do in general is around forming relationships with the folks that we're meeting with, that we're working with. I think the easiest and most important way to do that is creating safe spaces by respecting and recognizing the space that you're in. Just as an example, my outreach partner and I, anytime we're walking towards an encampment, will purposefully start having loud conversation. Clearly not about anything confidential, but just to allow people to know and to start thinking about and hearing that someone is coming. And then once we get closer to the encampment, we announce our full names, who we are, and what we're there for. And ask individuals if it's okay if we come in and share some information with them. If we don't get a response, then we talk through what we're doing, even if we know someone is in a tent. If they're not responding, we will say, this is Brian, and I'm an outreach worker. I just want to drop off some information. I don't want to bother you. I have an outreach flyer that has our information, our address, our phone number, and I'm going to drop off a bottle of water. And so we have a plastic bag that we leave, and then we say, okay, we're leaving now. We're going to be moving on. If there's anything we can do, please let us know. And in the winter, we do the same thing, but we leave a pair of socks with an outreach flyer. But always keeping in mind that this is their space, and I would never open a tent. I would never force someone to talk to me from inside their tent at any point in time. So really giving those individuals the respect that I would expect someone to give me if they were coming to my house. If I don't want to answer the door, I would assume most people are not going to continue to bang on my door or force me to come out and talk to them. So that to me is really the crux of creating a safe space and the start of a relationship that is really driven by them. We're there to help them with their needs, not whatever our needs are. Which I think goes right into trauma informed care and being trauma informed. I always like to tell people and think about universal precautions when we're talking about trauma informed care. As we all know, the vast majority of the people that we are working with do have trauma histories, but even if they don't, let's be respectful and assume that everyone is or does have some sort of traumatic experiences. And we want to be respectful of that and be able to provide a service that feels as comfortable to them as possible. Organizational policies and procedures clearly are imperative, very important. Definitely, I know can be a sticking point between administrators and people providing service at times. I think how you work through that is by having policies and procedures, by seeing for administrators, seeing is what goes into safety planning and the service that we're providing, and seeing that firsthand, going out on some outreaches with your staff. Um, it's very eye-opening, and I think can help administrators to feel a little bit more comfortable, but as an outreach worker also can make me feel more comfortable that the person I'm reporting to has some understanding and some support. And we've worked on these policies and procedures together so that there's a mutual goal of safety for everyone involved. Lastly, I tell people all the time, we have to go with our gut. We really have to listen to our intuition. And if things aren't going well, then it's okay to say, all right, well, I'm going to be moving on now, and we can check in another space, another time. Um, Safety is important for everyone involved. So listen to your intuition, listen to your gut, and make as educated decisions as we can. So lastly, and then we'll get into our discussion, is just kind of to wrap things up. Some strategies or things that I've already talked about, but just wanted to highlight again, are really following the resident's lead. I purposefully use the term residents here. In these individuals, this is where they are residing. This is their home for the time being, whether it be for a few minutes, a few hours, a few days, a few weeks. This is where folks are living. So let's make sure that we respect that and we also follow their lead. If someone doesn't want me in their camp or they're getting agitated about me being there, I'm going to leave. There's no reason for me to push forward. And if things aren't working for me or the individual that I'm working with or individuals, then be aware of that and pull yourself out of that situation to the best of your ability. You can always repair and talk about what was going on and what happened at a future date when tensions aren't so high or folks are not so frustrated. How do we do that? I think from having a relationship, having a trusting relationship with the folks that we're working with. So from the very beginning, that's where I'm always thinking is where can I connect? How can I connect with this individual to form a relationship so that they can trust me and we can do the work that it is that they want to do. Confidentiality, um, not going to keep pounding on it, but we know it's so important. And out there in the community, it does, people see it flexible at times. It's something that I'm pretty rigid about for good reason and ensuring people can trust me because without that trust, it's not, the relationship isn't going to be there. The work is going to be tougher to do for all of us. Lastly, supervision and team support is huge. No one can do this work alone. I know sometimes out there on the streets, we might feel like we're alone, but having a supervisor, an administration, and a team support, a supportive team is imperative in order to be able to do the work that we're doing. So moving on from here, I'm going to turn it back over to Barbara, and we will then move into our coffee chat discussion portion of our show.
Thanks, Brian. Just wanted to point out a few resources that are available for folks. The U.S. Interagency Council on Homelessness has put together a number of really good resources. A few years ago, they put together a document called Advancing the Dialogue that really outlined how communities can responsibly and constructively respond to encampments. They looked at systems building, collaborations, obviously outreach and engagement, and then how is it specifically that we can be getting them to a path to permanent housing. They've got quick guides, planning checklists, case studies of best practices in some communities. So I really encourage you to check out the USICH. And in particular, their more recent publication on some of the questions to ask about when you're thinking about sanctioned encampments or establishing safe zones. And what I really liked about this publication was a continued emphasis on what is the long-term plan for permanency and what is the long-term plan for housing. And so no matter what short-term crisis solution that a community might consider, that can't be it. It has to be connected to housing. And so I really appreciated them outlining some of the questions that communities are struggling with in figuring out how do we do both short and long-term solutions at the same time. We don't have to be competing for the same resources there, that we can be doing both. So I was excited about that, and so encourage you to check that out. Also just want to mention again the Tent City USA report from the Law Center, again, is a good resource. And then we're here at our questions and discussion. Here's just some of the questions that we had for you. I do want to point out the text box, our request. We are trying at the council to put together a web page that has best practices, policies and procedures, things that we can use as a clearinghouse and a resource so that when we get contacted about encampments, delivering care, how are we community partners, anything in those roles, that we have things that we can share from each other so that this community can continue learning from each other. We've already, so this is the link here, we already have the council's statement on encampments, the positions and some of the roles that we play, but we'd love to continue to build that. So I want to put a plug in for that. But in the meantime, I'll turn it back over to Lily so that we can get to your questions.
Thank you, Barbara. Thank you, Brian. And thanks to all the attendees who've been already introducing yourselves in the attendee chat. We've got a great crowd here today and people from all over the country in lots of different environments. So let's start at the top here. What sort of issues and barriers to providing care are you all seeing in your communities? A lot of folks are typing, so. Okay, so from Nicole Westling, permanent supportive housing units. from, go ahead.
So I think that this is something that the council has been talking about for quite some time, and we started with there is a dearth of permanent supported housing out there right now. So I would say encouraging folks to be involved as involved as you can with your city, with your communities, to bring that to the forefront. I know here in Worcester, I was just part of a city manager's task force, and that was the main objective of the whole task force was how do we secure more permanent supported housing units, um, in the context of having an increased number of encampments and people that are visible within the community. So we used that lens, that communities, that our community and some of our city councilors and mayor um, were fielding information about, and said, well, in order for us to work on this issue that you all see as an issue, uh, permanent supported housing is what we need. And we were able to come up with some really creative, new, innovative approaches, partnering with lots of different nonprofits and housing authorities and city and state and all of those sorts of things to get more permanent supported housing.
Several other attendees have echoed just the lack of housing, and also several people are pointing out that they're losing touch with clients when they're displaced or police sweeps are going through, and so they're not able to find their patients the next day.
Yes, I think that's something that I and we are all dealing with, and I, for within my community, it gets really tricky as well, um, between being informed that some sort of sweep is going to happen, and being notified uh, after the fact, and what do we do with that information? So uh, sometimes we get notified, and even which I struggle with, what do we do with that information? Because then I have also utilized that information to inform people, and then a connection with the police is made in the eyes of some of the community out there, thinking, well, how could you had to know something about this? People didn't know I was here except for you, so you must have let them know. That sort of thing. So that's something that has been a constant struggle for me in my outreach team. I don't really have a great answer, so I would love for someone else here to that has a great working relationship or some way to do this to give us some feedback.
Thank you. Several people are also writing about no places to refer people, such as on-demand treatment, shelter beds, or other options, sort of as the next step.
I think it's tough. I think these are all very real issues that, and why I love the council and being able to be part of a group of people who have shared beliefs and shared visions and also shared struggles. I oftentimes, as a path outreach worker, um, have done my best to uh, form relationships with every organization out there in order to get my clients' needs met, no matter if I think that it's actually going to work for one person or 30 people. So that could be, referring individuals to your health clinics, to your HCH programs. But what happens when they can't go there or don't feel comfortable going there? So also forming relationships with kind of more mainstream services that some folks might do well, and that's what they're looking for. Um, Even then, there's still really huge wait lists. everywhere, and getting someone in for any sort of on-demand treatment, I find to be really, really tough. But I think forming those relationships with people, and really those individuals recognizing that we're doing everything that we can to advocate for them and for to ensure that we're going to get them the help they need as soon as possible seems to be the best that I can do some days, and is appreciated at times.
I would also even add in, I think this gets to the different roles that HCH community gets put in. So as Brian was talking, like, how are you delivering services? But then what is the interface or the interaction of the relationships with other community partners, the police, and others who may have a different perspective on how this encampment what this encampment's future will be. And so how is it that your organization is working at multiple levels as well, so that your leadership might be forming relationship or agreements or working together again with you as a service provider, but also kind of doing a multi-level approach. And so it might be, if it's not possible to prevent a sweep or a shutdown, what's a harm reduction policy response? Can we be making agreements? Some people are talking about having in their Bill of Rights a 30-day notice or some kind of notice that's given. How is our leadership negotiating that with decision makers in the community? And how are we trying to be very clear with the people that we serve what our role is so that we can maintain that trust? But I think it's the trust we have with our clients and the residents in these camps. It's also the trust that we have with our community partners. So I just think it's a multi-level approach that kind of meets the roles that we're expected to fill here.
Thank you. And several folks are writing in the chat about the importance of relationships and those partnerships that you all have been talking about. Brian's slides mentioned a number of approaches that may be helpful for providing care in encampments. What other approaches have worked well for you all who are participating? Anything that that we haven't talked about yet, but that you would like to share? Many of you are typing.
I know while people are typing, one thing that I had heard that I thought was a really good way of trying, again, to mitigate and do harm reduction is there a way that you can work with your city to do trash pickup or do some kind of infrastructure services if you've got an encampment that's in an identified space? I think it's, the municipality comes to my house and picks up trash twice a week. And so if this is where people live, it's reasonable to expect the municipality to recognize that they still have a role to deliver services to their citizens. So these are the kinds of arguments and services that might be set up. Again, it's certainly not housing, but having trash pickup or having something like that might help with the cleanliness and the safety of the space. So just one thing to consider.
Thanks. And folks are continuing to highlight the importance of relationships. Catherine Croslin points out with the Department of Human Services to help with cleanups, and also the Department of Behavioral Health homeless outreach. So that just sounds like a foundational part of being able to do this work well. Nicole Westling points out that their team can order dumpsters delivered to the large encampments in the city. And yep, Brian Malikdem also working on neighborhood cleanups. So that does sound like another promising practice there. And Jason Albertson points out the trying to stay in the role of consultant to client and a resource provider and organizer, helping people cope with these impacts versus apologizing for them. What other trainings or materials could the council provide that would be helpful to your organization as you are continuing to provide care in encampments, or you're thinking about developing those services? What would be useful? Brian's mentioned certainly trauma-informed care, harm reduction also has come up as sort of general philosophical approaches that are key to this, to providing care in encampments. But what else would be useful? Brian, is there anything you'd say about training that you've gone through or others in your organization that has been helpful to you?
I think especially for new outreach workers or new HCH employees in general, I'm gonna make a plug for the National Healthcare for the Homeless Council's website, and there are all sorts of great trainings on there. I think trauma-informed care is something that you mentioned that is so important, and I think we have to continue to take a step further in terms of trauma-informed care for ourselves, not just for the participants or the people that we're serving. I would also say some sort of conflict resolution kinds of trainings are oftentimes really helpful given the tension that we oftentimes see with individuals who are struggling, dually diagnosed folks. Tensions are oftentimes high out in the community. Um, so that's another training that I would always suggest for folks is kind of conflict resolution. And how do you do that in a trauma informed way, as opposed to in kind of an authoritative way? So really looking at which one of those trainings that you would use. But those are a couple that I think would be at the top of the list for sure. Narcan training is something that is everywhere right now that is really important. That myself and all of my staff oftentimes do refreshers on. Um, CPR, first aid, all of those sorts of things that you would need to be out in the community and be able to help someone that might not be able to get out of the situation that they're currently in.
Brian, I had a question. You had raised Narcan and some other CPR training. Have you ever done a train the trainer or done a Narcan training in a camp for the residents there so that they could be in a position to be able to administer that if needed? And do you find that to be a helpful relationship development technique as well as obviously a harm reduction piece?
Yes. So we oftentimes give Narcan out to individuals. We also within our community, we have a wonderful organization called Project Worcester that does outreach to encampments specifically to train individuals on how to use Narcan. So typically, I would partner with them because they have the grant to do it and they have tons of Narcan. So they're that I try to partner with them. But if someone is active or in an encampment where people are active, it's an option that we always give people, is that we will absolutely provide you or give you resources to be provided with Narcan and training to utilize that.
Thank you. Brian, you mentioned earlier about the importance of a supervisory support and other staff support. There's a question from an attendee about secondary trauma. Is there anything you'd say about awareness of that and strategies to deal with?
Yes. So I think that's really what I was getting at just a minute ago when I was talking about trauma-informed care, not just for the individuals that we're serving, but also for ourselves, and ensuring that we are receiving trauma-informed supervision, and that our organizations themselves are trauma-informed in how they provide support to their employees. So yes, secondary trauma, we know there's a ton of information out there on it, but how do we provide a an environment where individuals feel and are supported through that? I think there's a lot of resources out there in regards to trauma-informed supervision. That's something that folks have not heard of. Just do a quick Google search and you can find all sorts of information. I know that the council is also working on some trauma-informed care project right now, so I'm sure that that'll be information that will also continue to be shared. But just having open and honest conversations, feeling and being supported by your supervisor, by the administration, your organization, I think is the most important aspect of working through the secondary trauma that we all see.
And several folks are noting that how critical Narcan training and use has been in encampments. There are a couple questions too about the specific tools and equipment that might go into an encampment with your team, and what specific medical care does it make sense to provide there versus going to the clinic setting?
So as a behavioral health, so as a PATH provider, we provide behavioral health treatment and peer support. We don't typically have a medical component. We do partner with our local HCH to go out if we can't get someone in. So I don't have a full kind of medical bag that I carry with me. So I would, be interested to hear. I'm sure there are other folks that are on this call that are providing primary care, medical care, wound care within encampments that could give a better example of kind of what does your outreach bag look like. Mine, I have a first aid kit. I have my cell phone. I have Narcan. I have water. I have socks. Hats, gloves in the winter, those sorts of need items that folks might need if we're out there, blankets and that sort of thing.
In the Clinicians Network did an issue of its clinical newsletter, which is called Healing Hands, a couple years ago on outreach, and got into some of those specifics. So I will, in just a moment, post a link to that issue in the links pod on your screen. But we've got just a couple more minutes here, and I wanted to give Barbara and Brian a chance to sort of wrap up the conversation today and share any final words.
Barbara?
I think from my perspective, this is really hard work, and I think that this is very specialized work. Specifically, as Brian had said, it's very distinct from the work we do in a traditional clinic setting. That said, this all happens within the context of a lack of affordable housing and all of the policies that are producing homelessness. And so we're working in an environment that sometimes can feel like a lightning rod because it's become so tense. And I think that's really hard for all of us. So I want to recognize that. And I want to recognize that I think all too often the communities are blaming people who live in encampments rather than the policies that created those encampments to begin with. And how can we be fulfilling our numerous roles to keep the conversation focused on the structural solutions that we need to homelessness, and trying to keep the blame off the individuals that have the fewest choices and the least voice in this, and desperately need the services that we're providing and the structure of housing that our communities should be providing. So that's my piece. Brian, curious, I know you have a different perspective just because you come at this from a different work.
Yeah, but I think you did a good job of kind of putting it into context for us, which is really important. And I think sometimes for those of us who are on the front lines doing this work, we lose sight of that perspective. That that there is a bigger context, that we need to be looking at this. But as an individual service provider, um, we have to focus on the individual that's right in front of us as well. So how do we do both? How do we both? How do we do both advocacy for the individual and the work that we do with them, but also advocating for them on a bigger scale? And that is definitely something that I compliment everyone here and encourage everyone here to continue to do. It is tough work. If anyone ever needs to chat, wants to talk, wants to commiserate, or share success stories, I'm more than happy to. And thank you all for the great work. And I had fun doing this new format.
Yeah, this is fun.
Thank you, Brian and Barbara, and thank you to everyone for participating and for all your comments and questions through the chat today. This was fantastic and a really great way to launch this Coffee Chat series. The next one is going to be this fall on the topic of family homelessness. The date is not yet set, but stay tuned to your council email channel and you will be getting information about that soon. So I hope you'll join us for the next one. There will also be a brief evaluation for this session that will pop up on your screen in just a minute. So if you could give us your feedback just in that very brief evaluation, we'd really appreciate it. Thanks, everybody.